I'm Marty Kaplan. I'm the director of the Norman Lear Center, which is part of the Annenberg School for Communication and Journalism at the University of Southern California. And the Lear Center, that's the Lear Center behind me, or it would be if we could be there. It's been almost a year now since we've been in exile. I hope you can come back and we could go back and see one another there. The Lear Center has just turned 21 years old. And the premise, the idea of the Lear Center is that media matters, that media makes a difference, that media shows us an image of the world, shows us who we are, and also shows us who we want to be or who we might be if things go wrong. And the consequence of those images and those stories are that people change. Their knowledge changes, their values and attitudes and beliefs change, and sometimes their behavior changes. Norman Lear, the namesake for the center, created All in the Family, which just is now celebrating its 50th anniversary. And if you look at the way in which that show affected America then, our premise is that that is happening and always happens. It's going on now. And the question is, what's the consequence of that? And can that impact, can that influence be used as a force for good, for improving people's lives? So that's what the Lear Center does. And we have a program within the Lear Center, which is 20-ish years old, called Hollywood Health and Society, which focuses on the way in which matters of medicine, health, science, security, and safety can all be treated in entertainment in a way which is accurate and timely and responsible. And we are now doing a series of webinars. This is the 17th, I think, jointly sponsored by the Writers Guild of America East and the Writers Guild of America West. So many of you are screenwriters, TV writers, and we're grateful that you're watching, and we hope that you get informed and inspired perhaps by what you see and what you learn tonight. So how TV can save lives, that's quite a bold claim. And we have a terrific panel that I think can justify that title. And that panel is going to be moderated by Neil Baer, whom you'll meet in just a moment. Neil is an experienced writer, producer, executive producer, showrunner of shows in entertainment Hall of Fame, really. ER, Law and Order, SVU, for example, designated survivor now. And in all of that, he has also maintained his practice as a pediatrician. Neil's an MD. And I'm also happy to say that Neil was a key player when Hollywood Health and Society was founded. He's been on our board, giving us invaluable advice, connecting us on the academic side to the entertainment community. So you'll meet Neil in a moment, but first we thought it would be informative just to see what TV shows have been up to in the short amount of time that they've been able to be in production since the pandemic. And so let's have a look at that, and then you'll meet Neil and the panel.
Hello, everyone. Thank you for joining us. Thank you, Marty, for the kind introduction, and thank you to Kate Folb, who runs Hollywood Health and Society. So we're here on this auspicious day to talk about what's on everyone's mind besides what's in Congress, which is COVID. And we're going to talk not so much about the early part of the pandemic, but what we can do now as protectors. And so as you just saw on that uh, series of clips, you saw that these are not shows that necessarily are focused on the whole episode on COVID, but they've integrated the storylines into their shows. So it may last for a few seconds or it may last for a minute, but the show isn't devoted to a discussion of COVID. Let me introduce everyone. First, Dr. Kenneth Reznikow, who is a professor at the University of Michigan, an expert on health communication. So we're going to be talking a lot about how we can communicate, particularly to those who are vaccine hesitant. And along with Dr. Larry Ahn, who's a physician and associate professor of medicine at the University of Michigan, and he's going to speak about the research as well. We're going to talk to Sten Vermund, who is the dean of the Yale School of Public Health, and we're going to get into all of the questions that I have about COVID now, from mutations to numbers of vaccines to what if you're vaccinated and someone else isn't. So we'll do that. We have Linda Ong, who's the CEO and founder of Cultique, who helped pull this whole discussion together. And we have Kate Folb from Hollywood Health and Society, and she is the director and pulls this together every week. So I'm going to move to Linda, and then we will get started. So one element that you saw in all of these pieces that we just looked at was that they talk about and integrate the issues of wearing masks, washing hands, not hugging, social distancing, all the things that we've heard about over and over in their shows. And this has an antecedent that goes back to the 80s, which was designated driver. And Jay Winston at Harvard School of Public Health invented actually this approach. And he literally took it to shows around Hollywood and asked the producers if they would incorporate that line. So it could have been in a bar at Cheers, or it could have been in a show like 30 something. And when I was doing ER, he came around and we put it into ER. The impact has been huge. So it wasn't a show about designated driver. It was a show where that element was integrated in a way that made sense, and it didn't hang out there. And so that's what we're going to talk about today, is how do we integrate these storylines about COVID into your shows. And they can be comedies, they can be children's shows, they can be dramas, they can be anything that you're doing. We can always talk about different elements of COVID in a way that is natural. So, and we also know from the research that Kate's group has done that it's hugely impactful. And our researchers today, Ken and Larry, will be talking about that as well. So I'm going to move to Linda.
Great. Thank you, Neil. Just wanted to give you a little overview on who all's involved in this coalition. We started this back in last March, the first week of the pandemic. We were very pleased. First of all, I should say Neil Baer is the godfather of this effort. He was the one that introduced us to Kate, and so we're very happy to have them both together today. Started with the University of Michigan School of Public Health coming on board, and the Yale School of Public Health, along with USC Annenberg Norman Lear Center, Hollywood Health and Society. The work that the Michigan team has done has informed the NIH guidelines that are currently out. And we've also briefed the teams of Dr. Anthony Fauci, Drs. Thomas Frieden, Dr. Jha from Brown University, as well as a lot of the doctors that have media platforms. In addition, we partnered with organizations like the Creative Coalition, Civic Nation, which will be the pro-social arm of the Biden administration. We've recently enlisted the Lincoln Project, And as well, we're partnering with the Ad Council, who just yesterday gave at their partner summit, designated the idea of appealing to people's desire to protect their loved ones as their #1 message. So that's very aligned with the protector approach that we'll be talking about today. In addition, we're very fortunate to count the support of amazing content creators, studios, and platforms. Some people I'll call out specifically: David Eilenberg from ITV North America, Eric Urian from Little Stranger, Tina Fey's production company. We've also had the amazing support of Perlina Ibokwe from Universal Studio Group, as well as Tracy St. Pierre, her colleague. Also from HBO Max, Sarah Aubrey and Jen O'Connell. Team Disney, led by Sharissa Gilmore and Herb Scannell from KPCC, have also all been amazing supporters in helping us in this effort. So I'm going to toss it back to Neil, and he's going to talk to some of our doctors about how we can save lives through TV. Take it away, Neil.
Thanks, Linda. So first of all, as you're hearing these discussions, please submit questions in the Q&A section, and we will have a time for that at the end of these conversations with our 3 panelists. So please send them to us and we will get to them. So going forward, first with Ken, let's begin with the question that's on all of our minds about who's going to take the vaccine and who isn't. And we call that vaccine hesitance. Though sometimes people say it's vaccine refusal, or these people don't know what they're doing. And so how many people are vaccine hesitant, and how should we even talk about vaccine hesitancy?
Thanks, Neil. Well, currently, about 27% of the US adult population, when asked if they're likely to take the vaccine, respond either probably not or definitely not. The good news is that number is down from 34% just in September. So there is an increasing trend of people moving towards the vaccine, but we still have to do what we can to help that 27% join us.
So we've talked in the past about, how important it is to discuss what is the best way to even frame this. Like, should we call it vaccine hesitance? Should we call it anti-vaxxers? How should we even think about that so that we have the most impact as physicians and researchers so that people will be less hesitant?
Clearly, that 27% comprises at least 2 audience segments. About half of that 27% is actually open to the vaccine. They just have concerns. And these concerns may be about safety. Will it affect their reproductive health? And then the other half are more what you might think of as anti-vax. They have an emotional, philosophic, and sometimes even personality-rooted objection that largely is immovable from fact. It doesn't mean they can't be persuaded, but education probably is not the primary approach with that subset.
So let's talk about persuasion, because that's what we do as writers. We have our characters persuade each other all the time. And what's the best way to send this message, which is not preachy or pedantic? Because we don't want to lose viewers because we're seen as preaching something or telling them what to do. We want to integrate it into our story so that it's natural, like life.
Very good. So if you look at what's on the screen, for the first 3 groups, we consider education still a very viable strategy. So one of the most powerful things you can do is ask them what information do they need to help them feel more confidence in the vaccine. The 4th group, the hard nose, which is that stronger anti-vax group, for that group, we have to use a very different set of tools. So for example, we like to do something we call roll with resistance. Another fancy way to say it is stop shooting all over them. Words like you should, you must, you have to. In fact, we saw that in one of the scenes that you shared. That tends to push them in the opposite direction. So instead, we like to reflect back what their concerns are, affirm that their motives are basically good, affirm things like you've thought about this a lot, you care about your health, you want to protect your family, rather than counter-arguing.
So give me an example of, some work that you've done or a story that you've heard or people you've come in contact with who might, use this example that you just said, like if characters were talking to each other, let's say, and
Yes.
one of them is, just very vaccine hesitant, what might be a way for the other character to speak to them, but not preach or tell them what to do?
Very good. So I can tell you from personal experience, working with both patients and relatives, that when they express and they throw out this salvo that they're expecting to be argued with, and you reflect with, boy, you've really thought about this a lot, or you really care about your health, or you have a lot to say. We're not actually agreeing with the untruth, but we're sort of affirming their basic humanity, and we're softening the ground so that the seeds may grow. And so in interpersonal interactions, to try and affirm positive attributes about their belief system, that might increase their openness to possibly shift or to be persuaded.
So if one of my characters said, I'm really just, afraid because they haven't done enough research. This was too fast.
Yes.
What would the character who is trying to help them move to the position of taking a vaccine, what would they say?
First of all, that happens to be the number-one barrier for African Americans, more so than an explicit statement of medical mistrust and it's that one issue of, was this developed? Something along the lines like, it sounds like you're actually interested in the vaccine or open to the vaccine. You just need some additional information. It's sort of, again, just reflecting back, but yet subtly nudging them towards change by affirming, I'm hearing that you're willing to go north if we could clear up some of your concerns.
So I'll play that character. So my next line might be, well, how can I be sure? How can I trust what's going on with the vaccine?
So we would reflect back. So it sounds like you're uncertain, Neil, that the vaccine is safe, that it was developed with adequate science behind it. If it's okay with you, Neil, I'd like to share some information. We call that elicit, provide, elicit. It's a fancy term for letting you drive. I'm letting you control the information exchange. I'm armed and ready with facts, but before I start what we call information dump, I try to get your buy-in, support your autonomy by saying if it's okay with you, or tell me what you'd like to know. That little extra step, again, opens the person up better so they can receive the information. And again, this could be in a character interaction, just like you're trying to set up. A sophisticated relative, or it could be a physician or a healthcare provider in a show, could use this technique, and then the person should respond positively to it.
So as we're talking, what if I said, the word resistance? Why is it important to talk about hesitance as opposed to resistance?
Well, I think resistance is perhaps a better term for it, because resistance implies energy, that they're using their energy to push against. And Larry, who's talking next, is actually a very skilled martial artist. He knows that sometimes the best way to flip people is to use their energy. And when we take them off guard by reflecting, again, these positive things, sometimes that negative energy shifts from attacking because they're in a defensive mode to sort of having this epiphany of, maybe I don't have to push back if we don't push back. So in general, we don't push back when someone argues. We say it's a dance, not a boxing match.
So it's really a conversation. It's not drawing a line that can't be crossed. And that's really dialogue in shows. And so I think you're making it a really clear point. Now, if you wanted to show conflict and not be socially constructive, then one could do that. But I think that we really do want to do things that are pro-social and that will help people overcome their hesitancy. You mentioned that there is a certain type of hesitancy amongst Black and Brown also populations. Can you talk about the history of that, and are there different approaches with different communities?
So when we put folks into these 4 audience segments, we put the African American resistance into the legitimate concern category, which is actually great news, because it means that education or information can assuage their concerns. As I mentioned, but I'll get specific for a second, although Tuskegee medical experimentation and unethical treatment by the healthcare system is part of it, when you actually ask what's bugging you, we refer to the African-American opinion as not anti-vax, but anti-first. The most common expression is, yeah, I'm interested, but let someone else go first. Let them experiment on those guys, but I'm open to it. I just don't want to go first. So one of the goals is to try and add autonomy to the system of letting people of color know you don't have to go first. Other people have already gone first. There were, in fact, other people in the prior trials, but also if you go a couple of weeks later, if you want to stay on the sidelines and see what happens, in general, we think that's a good message. And even giving them that choice might soften that they'll even go earlier. So the key thing is to support autonomy, not make them feel like they're being pushed a little bit too soon, too fast.
And yet, as you're saying, we must respect the history, because there is a very sordid history of experimentation, particularly amongst people of color and Black people. I have a friend who just wrote a piece in JAMA about experimenting on Black prisoners to develop the drug Retin-A. And they made a lot of money doing this, and it hasn't been fully acknowledged until recently. And so I think it's important that we acknowledge, which in those clips you saw, there's an acknowledgement and not making fun of or, questioning their views, because those views are embedded in a very stark history. So I appreciate what you're saying. And so then the question becomes, if people, decide to let others go first, it's still important that everyone get vaccinated. But why can't we just, say to people, well, we understand, it's okay. You don't have to get vaccinated, apart from people who can't be vaccinated because they have immune diseases and things like that.
So just to go back 1 second to your very powerful statement about exploitation and medical maltreatment, that same technique could be used here. So you would use reflective statements back. You're right, the US government has historically mistreated Black. There's no reason to argue with that and no reason to contest it. The question is whether or not an individual wants to let them impede them from getting the vaccine. But now going back to your more recent question, the math tells us the answer to that. That if we have to achieve, let's just say 80%, and we have a real expert, Dr. Verman on the call, but if let's say we need about 80% to achieve herd immunity, we can't afford to abandon that 27%. We need them to get to that herd immunity. So we were gonna have to, for even our own self-preservation, work with that group and use some of these techniques and sort of drop the whole need to be right or wrong and just try and get as many people in the boat rowing in the same direction as we can.
And you made the point about hearing people, which is what we're always doing as writers. Sometimes our characters don't listen to each other, but basically this is an approach of not you're wrong, or you're going to get sick, or you're going to make other people sick, a blaming approach, but it's more of a give and take of listening to one another. And you said reflect and affirm. So can you take what I've just said and kind of go a little bit deeper on maybe perhaps an example of what you've seen with reflecting and affirming?
Yeah, so we've demonstrated a few times, but I'll give you a couple other ones that could occur in dialogue. So if a character expresses this idea that it was developed too fast and therefore can't be trusted, you would reflect that back by saying, you're right, the vaccine was developed in record time, and you're really worried about that. You're worried that shortcuts were taken before the approval. And again, it's just meeting them where they are. And then we would again ask, what information can I give you? This would be more appropriate from a healthcare provider than maybe an aunt or a spouse, but nonetheless, it could be worked into a scene. What information can I help you? Or I have information I'm happy to share with you about the development of the vaccine and the rigor of those processes. Again, letting them drive, but giving the permission stage.
So it's really being, the bottom line is being respectful about hesitancy, because hesitancy comes out of many, there are many reasons for hesitancy. There are cultural reasons, there are historical reasons, there are political reasons, and we need to figure out ways to have the conversations where we hear what someone's hesitancy is about, and then we give them some alternatives to think about.
you bring up one of the more interesting challenges, that for many people who are either hesitant or anti-vax, that position aligns with their deeper values. It aligns with the value of being independent, intellectual, protecting themselves from being brainwashed. So the way that they've constructed their belief system, their values against being vaccinated are actually consistent with what they say they value on this planet. So we have to work around that. And Dr. On's going to introduce a very, I think, wonderful concept that will move that motivation out of your own perceived risk and out of your own sense of vulnerability, and move the motivation to protecting others that can still preserve all those other independence and authority issues going on.
Great. Well, thank you. Thank you, Larry. I think this brings up, and it's a great segue to Larry On, which is, we're in a time where we see people who have really staked their flag on their beliefs and say they're not going to change. And so that's very complicated. And, we see this sort of us-them approach in politics today in Congress. And so as writers, we look for ways to move conversations forward and to really address social issues, as I did on ER and SVU and designated survivor, and as many of these writers do. And as I said, it doesn't have to be the whole episode. It's just, it comes up as it does in life. So Larry, I want to ask you, and thank you again, Ken. So I want to ask you now about these pathways to overcome resistance and strategies that writers can use, so that we're not just, in a tug of war. We don't have, people who just say, you're wrong, or I've done special research. How do we have these conversations? And so in order to understand what we can do as writers, we need to know what Ken was just talking about. What are the attitudes? You've done a lot of survey research about COVID. What are these attitudes? And then we can talk about pathways to overcome resistance.
Wonderful. Thank you so much for the opportunity to come on the show. And thank you to Marty and Kate and Linda and everybody for this opportunity. So with Ken, we've been looking at attitudes and behaviors related to COVID-19 since the spring of 2020. That sounds like more than a year ago. And so we've been doing national surveys looking at beliefs and attitudes about COVID-19 and about COVID safety practices, particularly related to social distancing. And what we found, and this was sort of novel at the time, but I think is probably going to ring true, is really separate dimensions of thought related to COVID safety practices. So there's a set of people, a fairly large set of people who are thinking about health and safety when they're thinking about COVID practices like social distancing. And then there's another also fairly large group, and it's not going to be surprising to people, that's really thinking about rights and freedoms. And what we found is that thoughts about health and safety and thoughts about rights and freedoms, they're not on the same continuum. These are like separate dimensions of thought. And what we actually found is people that have beliefs that COVID safety practices violate their rights and freedoms, it actually doesn't matter what they think about health and safety. They're not following the safety practices. So you could, just to be concrete, you could have somebody that does believe COVID is a threat and COVID kills people, but if they feel that COVID safety practice violate their rights and freedoms, they're not following COVID safety practices. And where this was a bit of a conundrum for us, because in the public health community and in the medical community, we're very used to telling people, this is good for your health, you need to protect your health, this is a health and safety issue, and it's so very, very important. And I think finding this different dimension of thought, which is, let's just say, evident in other parts of our society as well, in other events, it's maybe not that surprising that it overrides or trumps beliefs about health and safety. And so that was it was a head scratching moment for us. And when we were trying to figure out, so how do we wrestle or grapple with this other dimension of thought, which is overriding concerns about health and safety, a friend of mine called me, and we have his permission to share his story and his slides. So I don't know if we can bring that up. This is my friend Adam. Adam, I know through, I think Ken mentioned, I do martial arts. And Adam was one of my first teachers. He's a black belt in something called Brazilian Jiu-Jitsu. And he called me sort of out of the blue when I was wrestling with these survey questions about how do we deal with these issues, to ask about how to be safer from COVID. And let's just say, I didn't really expect a phone call from Adam of all the people that I knew. So Adam is, as you see, a bit of a character. You can't tell here, but he's kind of big too. He's like maybe 6'3", 6'4". He is an, let's say, independent right-leaning thinker, and veteran, gun enthusiast, rock guitarist. Not the typical type of person I would be expecting to have a COVID conversation with. And he called me because his wife has some issues with her immune system, and he really wanted to make sure that he was following the right COVID safety practices. And in fact, we went over the set of practices he was following. He was being very meticulous in all of these behaviors and activities. And it sort of dawned on me as I was having this conversation with Adam, it's like, Adam is not motivated by his concerns for his own health or safety. He is entirely motivated here by a concern for the safety and well-being of his wife, and he is motivated here. So we took that thought and we actually went back to our survey data, and we looked at the relationship between sort of risk to self, perceived risk to self from COVID, and perceived risk to others. And what we found is the risk to self, whether that was high or low, it did not reduce this belief in the rights and freedoms that COVID safety practice violated rights and freedoms. But if people had concern for others, only then and only then, we saw a decrease in these attitudes that it's all about my personal rights and freedoms, because they were concerned about the health and safety of others. So I think there was a direct benefit in terms of it was motivating to that motivation for the other and to protect the other was tremendously important to Adam. And what we found in our national survey data, based on Adam's story, that was true as well. The other thing that Adam shared with me, and one of the very sad things is some of the, also evident in broader society, how the conflicts that can arise over things that you might not expect to see conflict about. But there's conflicts in anti-masking and protests against social distancing. But Adam tells me, and we've done some additional work talking to other people serving this protector role, when most of the time when people learn that I'm not wearing a mask as a political statement, I'm doing this because I have somebody very close to me, I'm trying to protect them from COVID, it sort of diffuses the situation. It's a little bit like a psychological foot in the door that allows more conversation to happen. So this were some of the big lessons from Adam's story, and we followed up on both our survey work and our this experience with Adam to do focus groups. So we've done a series of focus groups. This is in the state of Michigan, which is, let's just say it's a state of diverse opinions. It voted a certain way in the presidential elections, but almost had its governor kidnapped as well. So let's say we have diverse opinions in the state of Michigan. And we've been doing focus groups with people who identify themselves as protectors, people protecting themselves and others from COVID-19. And if it'd be useful or interesting to you, I could share some stories from those focus groups because I found them very moving and poignant, and that they've given us some direction and thought in terms of some of our communication strategies.
That'll be very helpful to us as writers. So let me frame it
Okay.
in terms of what you've said. So if I'm following you, it's really important to ignite empathy. But I think what you're saying is that's an empathy that's not this generalized protect your community. Like you may go out there and infect people you don't know, but it's more of a strategy of protecting those you do know. And so one question would be, do you agree with that? Is it from your research, should we be talking about the community that we're protecting, or should we be more focused on, friends, family? And is that a good thing for, socially, for the social contract? And secondly, um, you know, when you're talking about empathy and loved ones, what is your research showing in terms of next steps? Like, what if you don't have someone to? How do you frame it so that it's someone to protect? Because your example with Adam is pretty clear. His wife has an autoimmune disease, and so if she gets COVID, she's in big trouble. But what about somebody who doesn't have family or friends, who is perceived at risk, like Adam's wife? So if you could speak to this question of the individual families, friends versus the community, is that too broad, or not focused enough? And then talk about also how we can construct stories and use stories that where there's not someone in danger. How do we use this idea of being a protector?
Right. So you've hit on some really big points. Some of them are, I will just say, above my pay grade. I'm not sure I can answer all of these questions. Our data shows, at least what's clear from our data, is that it's a concern for those that people already care a lot about, right? So it's close friends, close family. And following Ken's idea of, the path of least resistance, I think it makes sense to start there. Hopefully by thinking about some people outside of ourselves, that's starting people on a path towards a broader concern. But I think the important point to reinforce with me, the first argument is not just about broader society. There's a lot of need for people to protect people that are close to themselves. An interesting fact that most people are not aware of is that if you actually look carefully, and this information could be presented in the way that Ken talked about, eliciting understanding, asking permission to provide information, is that a lot of people actually have risk factors for severe illness or death from COVID-19. Probably 40%, almost half of the population can have one risk factor or another, whether it's related to age or being a little bit on the heavy side, high blood pressure, a range of not perceived as sort of immediately lethal or super complex, but very common, but important health conditions. So I think it's recognizing that the umbrella of risk is actually spread very wide across society, and that if you actually think about it, almost everybody that has somebody else they care about, somebody in that group is going to be at that sort of risk. So I think there's not a simple answer to your question, but a recognition of all the ways in which people might have risk is important to consider. And I think naturally people care first about those closest to them. The challenge that we would add, I think, start there, but then the challenge that I think that your work and the work of this whole initiative, and I'm referring to the USC and the Hollywood Health Society, is how do we sort of generalize the good to make a bigger impact? So that's something that maybe others could speak more about later.
And I think we may be developing or have some fact sheets that will speak to what you just said. I mean, I think most of us, who aren't physicians, don't realize that so many people have risk, and so that's important to know. And it's also important. The research shows, as you're saying, Larry, that Paul Slovik's work, for instance, says that we don't respond to genocide, sadly, because it's too many. Our brains are not wired that way. But when we tell a story of one or somebody we care about, then we have an emotional reaction. And that's what, of course, television and movies and plays are about. They're telling the stories of small groups of people, which that's why I think you're saying it has a huge impact. And if we started to write more broadly about the impact on society, it kind of then drains away. It's about, like it or not, whom we're related to, whom we care about. So I think that's important in talking about how to frame the protector in various ways. So let me ask you, how would you, if you were doing a show, how would you show a protector as a kid, as a grandmother, and as somebody who's on the front line working in a grocery store. So those three, like what would you, there are all kinds of there are different kinds of people.
Right. So I mean, unlike you and the people in the audience, I'm not a screenwriter or a storyteller at that level of expertise. I think what I can share is it's just a tremendously, it was tremendously powerful for me to hear people's stories. And these were protectors and focus groups from around the state of Michigan, from diverse communities all across our state. And it was interesting to see all the different types of people that were playing the protector roles. There's the fairly traditional, what you might expect, the daughter protecting her mom, right? But then there are also sort of heads of multi-generational households. There were divorced spouses trying to make a difference back to the other parts of their family. There was a son, an older son living with his even older father on an apple orchard in rural Michigan, trying to stay safe. There was a young adult who moved into their parents' basement for a bunch of different reasons during the pandemic, but then also was trying to protect them. So there's just so much variety in terms of the type of people that take on the protector roles. And then people's motivations were so poignant or powerful, right? Whether it was, having a parent with cancer. There was a really poignant story, a woman who was in her second marriage. Her first partner had died in the intensive care unit. So she'd seen a death in the intensive care unit, and she was incredibly motivated not to have her new expanded family have deaths in the intensive care unit. So it was those very powerful human stories that people were sharing. And I think that it's the creativity of your writers that can sort of tap into sort of their existing storylines and characters to pull those motivations out. But those are just some of the things that really struck home with me as people were sharing their stories.
So what's so powerful about what you're saying is that everyone can be a protector, and just like designated driver, which is very clear, if you all are going to drink, somebody shouldn't, so that they can drive everyone else home, or now use Uber, Lyft, or they'll be the designated driver. But there's a plan in place. So how would you like to frame this? Is it be a protector? Is it everyone's a protector? Because it's very powerful when you start to look at your characters and sort of do a deep dive with them and say, well, how is this character of mine a protector too? How might they see themselves in a new light?
So I think that's really a great question. And I think that can be answered in as many different ways as people have characters, right? So I think one powerful thing about the protector motivation is that it can help us reach, let's say, a demographic that's been pretty resistant to health and safety messages. If you think about the people who have a strong belief in rights and freedoms, a lot of those people are also motivated by a desire to protect their family from threats from the outside, right? And so being able to leverage that is an important strategy. So I think that's one approach that can be powerful. I think the other thing that sort of impressed me anyways from the focus groups and stories, just the incredible complexity and richness of this sort of protector behavior. We had people trying to be the protector or one of a small group of protectors in multi-generational households. So that was really interesting. They told a funny story where they had called people to dinner, and people showed up at the table that they didn't even know were in the household, right? Friends of grandchildren and things like that. And so that triggered a conversation and some strategies around COVID protection that were tied into their existing relationship and the ways they communicate. So that was important. Some of the complexities of serving as a protector in these sort of blended families, where the families might have different safety practices, trying to sort of negotiate and find sort of a common ground that people can arrive at. That was really interesting to hear about. And then, of course, everything sort of layered on top of this is people are trying to I guess, communicate, influence other people. Sometimes we're trying to do that. We can actually physically be in the same space, but there's an extra layer of struggle and comedy sometimes when you're trying to do it over Zoom, right? So that's just another reality I think we've all been living with. If there's one thing I would want to share that I think is really important for your audience to hear, is the people serving in this very critical role feel a tremendous isolation and loneliness in terms of their work. It was great, the clips that were played at the beginning. And so I think there is this public recognition of many of those clips featured people working in healthcare, and I work in healthcare, so I'm all for recognizing people working in healthcare. But these people don't feel like this important job that they're doing, which is so tremendously important, they don't feel if that's being recognized more broadly. And oftentimes, let's say you're the protector, one of your frustrations or challenges, and I'm sure this is something that happens in situations for all your writers have dealt with, is people are trying to protect people who aren't really doing as much as maybe they could or should to protect themselves, right? And so there's, let's just call it drama or comedy in those situations. And there was very much the feeling of the good deed that was being punished for people serving in this protector role. On top of that, all of us, I think, feel a little bit of fatigue from COVID. Protectors are becoming fatigued. And it was amazing to see in our focus groups, as protectors were talking to each other about their experience, them saying, oh my God, I'm not alone. I'm not the only one who's feeling this way, doing this to try to protect my family and having these struggles. And they talked about how tremendously valuable and important and motivating for them to help them sustain their protector activities, to just even see that recognition or role somewhere. So I've talked a lot. I want to give you a chance to frame that the appropriate way for the audience.
No, I think that's great that you've talked about not shame and blame, both you and Ken, but a more empathetic, listening, reflecting back, conversational, and then the protector side that really draws on empathy and the research that you've done that shows what works. And I hope that we can incorporate those pro-social elements in any kind of story that we're doing, where it seems like it fits in naturally.
What we have seen, just in terms of going back to some of the survey research, people that have protectors in their lives, right? So people who have people in their network that are supporting COVID safety practices, they're twice as likely to be practicing COVID safety practices than people who are not, right? And so that's the importance or the impact of this role. If you could, spread that more widely, right, that type of intervention is not exactly the COVID vaccine, but it makes a big difference in terms of reducing transmission of COVID.
Well, that's doing the modeling, which I think is very important. And as you just said, I was just going to ask, like, if you've done the research yet, and I'm going to move on to Sten, is there research on this kind of modeling? Is someone likelier to take the vaccine then?
So I don't have specific information related to the COVID vaccine and their willingness to take the vaccine. The data I'm talking about is people's report of whether or not the people in, their friends and family, how supportive are their friends and family of COVID safety practices? If people are in contact with other people who are these protectors, they are twice as likely to adopt appropriate COVID safety practices. So I think it's a very powerful effect that we can hopefully highlight. And I'll just close with, these people who are serving this very important role, they feel like there's been recognition of what are like frontline workers. They've sort of referred to themselves as the home line or the second line. And just, it would be so valuable to them in terms of being to maintain this important behavior, to see it recognized somewhere, whether that's in a show or even just have a character doing it would be so, they told me it would be tremendously valuable. So I just wanted to share that with your audience.
Right. And we know that from so much research about modeling and its effect, like on cigarette smoking. That would be another example where we don't show it. It's people are, when we show cigarette smoking, people are likely, or particularly teenagers, to smoke. So thank you for, sharing all of your research and story ideas that we can begin to incorporate. We're going to move to Sten Vermund, who's the Dean of the School of Public Health at Yale. And I'm going to just pepper him with questions that are on my mind. And then if we have questions from you all, we'll go forward. So hi, Sten. Thank you for joining us. So first question, mutations. So should we be worried? We're hearing lots of stories about the mutation of COVID-19. Will the vaccines work for mutations?
Bad news and good news, Neil. First, the bad news. The UK variant and the South African variants are real. They do appear to be more infectious. Our data are still pouring in on that, but early indications from unpublished data do suggest that super spreader events could be more common with these variants. We have a substantial number of the UK variants in the United States already, and they've already resulted in small spreader events. South African strain is bound to get here inevitably. It'll take its time because there's so little travel, but eventually it'll come. So that's the bad news. This is not a shock coming from an RNA virus, by the way. RNA viruses, as you know, HIV is one, influenza is another. They mutate. They mutate at higher rates than DNA viruses do. And we're not surprised. But here comes the good news. The mutation location does not seem to interfere with the principal protein on the spike protein, the principal, what we call in the field, an antigen. An antigen, of course, is the protein that stimulates an antibody response, that stimulates our immune system to attack it. And it looks like the antibodies that we produce in response to our vaccines are going to work for all of these strains. That's what the molecular modeling suggests, and it looks pretty solid. I think our virology friends are confident that the family of vaccines being produced it has targeted what we sometimes call a conserved region, which is not hypervariable across these strains. Now, that's not to say that strain number 3 coming out of who knows where won't disrupt that, but so far so good. So bad news and good news.
Because flu is different, right? So
flu is different.
So does flu change, and it's like the conserved areas keep changing in flu, so we have
Correct. One of the holy grails in influenza vaccine research is to find a conserved region against which we can mount an immune response. So find an antigen that every kind of flu vaccine is going to have this. It's a fundamental component. And we're making some progress in that arena, but we haven't found the Holy Grail yet. In fact, that's the topic of a very intense investigation at NIAID, directed by none other than Tony Fauci. And they are very much looking for what's called a universal flu vaccine. And stay tuned, we may get there. But as it stands now, we're targeting 2 proteins on the surface coat of flu, hemagglutinin and neuraminidase. And there is what we call drift of the virus between seasons. So there are enough mutations, so you end up with a virus for which last year's vaccine just isn't good enough. And we're always trying to keep 1 year ahead of this, of the emerging flu viruses by trying to guess what the emerging flu strain is going to be the next year, and then producing vaccine for that year. Sometimes we guess right, and we have a 65%, 70% effective flu vaccine. Sometimes we guess wrong, and we have a 35, 40% effective flu vaccine. But keep in mind that even the 35% flu vaccine massively reduces risk of hospitalization and death. So even when it doesn't prevent the flu, it down modulates the severity of flu. And that may be the case for coronavirus vaccines as well. If some strain emerges from Kyrgyzstan or, you know, wherever, Greece, and it's a little different in the spike protein, our vaccines may still be partially effective and may still prevent ICU admissions and death.
So it's important to get the vaccine, of course, and tell us now what you know about the Pfizer Moderna vaccine in terms of what happens if you don't take both. And the second part of the question is the next one coming down the pike, the Johnson & Johnson vaccine, how is that different? And should people wait for the Johnson & Johnson? How should we be thinking about, you know, should more people get one dose and not the second dose?
Great questions. What I would say is that, first of all, you've got the Moderna vaccine, which is an mRNA vaccine. You've got the Pfizer vaccine, which is another mRNA vaccine. And there's a little bit of drama there because we've never had mRNA, messenger RNA vaccines before. These are the first mRNA vaccines ever developed and deployed for human use. So one has to be pleased to see this level of scientific innovation, because there are a lot of reasons to think the mRNA vaccines are going to be especially effective and also especially safe. So the Moderna product looks like the optimum time for second dose is about 4 weeks. And the Pfizer product, the optimum time they're saying is 3 weeks. But all vaccines are tolerable if you take them a little bit later. So I don't want anybody on this call to be panicked that they can't get an appointment for their second vaccine for another week or another 2 weeks or even another month. It will still be highly immunogenic, is the technical term we use, stimulating a strong immune response if it's a little bit later. So that's the way that we're thinking about the booster vaccines, is really to enable the immune system to see the mRNA antigen twice. We wanted to see it first time, develop an immune response, then a little bit of a delay, and then we wanted to see it a second time. The reason you can't take it on day one and then take the booster 3 days later is because the immune system won't see it as 2 doses. It'll only see it as 1 when it's proximate that way. And sometimes we wait a whole year for a booster, depending on what kind of vaccine and what kind of agent we're trying to protect from. Now, you asked about Johnson & Johnson. It looks promising from the clinical trials that they will have something to show for their product by February. And it is a completely different type of vaccine. It's not an mRNA vaccine. It's what you might think of a more conventional vaccine. And the good news is it looks substantially immunogenic with a single dose. So you can imagine that would be huge for the global market. Another piece of information is that you do not require extraordinary storage requirements. These RNAs are vulnerable to degradation. So the Pfizer requires minus 80, which is minus 80 degrees Celsius, which is basically dry ice, or a very substantial research caliber deep freeze. The Moderna still requires minus 30, which is ice. And the reality is that makes it awkward to ship to Burkina Faso or Central African Republic. I mean, we need vaccines for the globe, and I doubt that the mRNAs are going to be the first choice of the WHO or Gavi to ship to tropical low-income countries.
Right.
But J&J, their product looks very promising, and it may very well be that that's the one that can be sent to developing countries. There's also the AstraZeneca vaccine, which has had a couple of hiccups, but it still looks pretty promising. And I think that at the end of the day, that is what they call a live vector. It's a different virus that is what we call replication incompetent. It can't fully replicate in humans, but it starts to replicate, and that stimulates a very vigorous host immune response among us, among humans, and presents the antigen in a very lively way. The immune system is sort of woken up, slap, 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 wake up immune system. There's a virus coming in. It turns out to be a dud virus, but it has presented the antigen of COVID, and the immune system sees it both with the antibody response and also cellular responses. So the AstraZeneca is also promising, also easier to transport, also cheaper. So, and then there are 4 more that are in the pipeline. So by next summer, we may have 6 to 8 licensed vaccines that are available to us. And if we can just get the up-to-date clinical trial data from the Chinese, and if the Russians publish their phase 3 data, which they haven't done yet, then we may have a Russian vaccine, we may have a Chinese vaccine. Chinese vaccine is interesting. One of them, there are several in China. One of them is a killed product, just like Jonas Salk did in the 1940s and early 50s, a killed product vaccine. So you take the virus, you kill it, and you stimulate an immune response.
So this is good news. Please send us any questions that you have, because we're going to go to that. You just said that there'll be a large number of vaccines by next summer. When do you think? We hope. When do you think? So can you even give a best guess of when we'll get through this, when people can go back to work, when Hollywood can start really going into production and not closing down when someone is COVID positive?
Now we go full circle to the beginning of this symposium, and we get back to Ken and Larry and Linda and Kate, and we get back to are people going to take this vaccine? So the issue around herd immunity is that it kind of depends upon how infectious the virus is. And it also depends on things like population density and this sort of thing. And because this virus is reasonably infectious, it seems like a bad influenza. You have to have a large proportion of us who are immune. And what happens then is that if 80% of us are immune because we've been vaccinated, then the virus has trouble finding a susceptible individual. It's bouncing around within our social and work circles, and it's dying to jump from the infected person to the uninfected person, but it keeps bumping into resistant people who are immune. And but if you're under that 80%, if you're only 60% coverage, then it continuously finds people who are susceptible and continues that transmission cycle. Now, how are you going to reopen the Disney Theater in Hollywood when you still have people who are susceptible and you still have transmitting virus. So what we're looking to do is drive transmission to exceedingly low levels. We might have some surges in the winter flu season, but modest surges. So it turns into like flu instead of like coronavirus. And it kills some people, but not very many, just like flu does. Flu kills 10,000 people a year in a good year and 50,000 people a year in a bad year. So we would like to up flu vaccine coverage as well. We don't do as well with that as we should, with a lot of preventable deaths from flu. But there's more consciousness for coronavirus. And if we don't get there to that sort of 80% level, then we're going to continue to inhibit the schools of our country, the arts organizations of our country, any public gatherings, future Trump rallies, they'll all future, motorcycle rallies, whatever it is that brings people together is going to be a risky scene. So we double back to Larry and Ken and the agenda that they put on the table for us, the drama inherent in the need to row the oars to pull the boat in the same direction as the American people.
Getting as many people vaccinated as possible. And when you were talking about the summer, were you talking about this summer or the summer of 22?
If we could get people vaccinated, we're going to have tens of millions of doses being produced in the next few months. And if we could go from sort of 8 million now to 80 million by April and 180 million by June and 260 million or 280 million by August, you could open schools up unhesitatingly. You could open up Lincoln Center in New York. I mean, Broadway could reconsider. So the stakes are very high if we want to get back to normal and try to restore some economic integrity to our country, not to mention our beloved arts, our beloved sports, what many people think makes us human, the pleasure we get from our recreation and from our creativity.
That's an important story, of course, to tell, that the more people who get vaccinated, of course, the sooner our lives will go.
The stakes are high. I have friends who have lost their small businesses. I see it in my hometown. I see it in New Haven. You see it in LA. I mean, it's not a pretty picture.
Right.
A lot of suffering out there, and we need to work on this, and vaccines can get us there.
One of our questions was about whether, we're being told that people who have had COVID, who've had a positive result and may have been asymptomatic, should still be vaccinated. So can you explain very briefly why that's important?
Yes.
And what that means?
Yes, we do not know how durable the immunity from natural infection is. We do not know whether we're going to wane in our antibodies over 6 months, a year. There's some good data to say that we're doing pretty well for 8 months. But we haven't had the studies for more than 8 months. Studies that have been a year are going to be published next month. So the reality is that we are ignorant of the degree to which we have robust immunity for years. And there is no harm in somebody who got infected getting a booster dose. That's functionally, you can consider the original infection as the vaccine turned out to be a live, non-attenuated, a live, vigorous virus. So it's not strictly speaking a vaccine, but it has a vaccine-like effect by creating immunity. And now your vaccine doses are going to boost you. So there's no harm in that whatsoever, and only potential benefit.
Can you transmit the virus if you're vaccinated?
The $1 million question. I taught vaccinology at a previous school of public health for 11 years, and there's not a single vaccine in which you reduce the viral load and thereby protect you from getting sick, but you are just as infectious. Measles, you're less infectious. Rubella, you're less infectious. Mumps, you're less infectious. Influenza, you're less infectious. So an intelligent guess is that for coronavirus, the vaccine, which reduces the viral load if you get exposed to the true virus out there, and therefore you don't get sick, is also going to make you less infectious to others. But we do not know that yet. And if there's compartmentalization of the immune system, and if systemic immunity, the system of the body, is vigorous and protects you from lung disease and circulating virus in your blood, but doesn't really protect your nasal passages, the mucosa of your nasal passages, you could theoretically still be infectious. I'm going to guess that that's not the case, but the studies have not come out yet. And we're thinking, Larry and I, that the studies are probably going to come out in by early March, because they're going on right now. So there ought to be a big enough cadre of patients. If we can get 100 infected patients who are documented to have been reinfected, or 100 vaccinees who've been documented reinfected, we can get the answer to that question. Those studies, I can tell you, the Europeans are doing those studies, the Chinese are doing those studies, the Russians are doing it, the CDC is doing it, the NIH is doing it, the US military is doing it. It goes on and on. And so we're going to have a definitive answer to that question about 2-3 months.
So we have a question. Thank you, Sten. So we have a question for Dr. Reznikow and Dr. Ahn, which is, do you have any evidence of the impact of your studies on being a protector with different audiences? In other words, the various kinds of audiences that watch our shows, they may be audiences that are different ethnicities, people of color. Do you know from your research yet whether being a protector varies amongst different groups?
I'm happy to tackle it first and let Larry chime in. We know from a very nicely done study that was published last week by the Kaiser Family Foundation that there are two fundamental reasons people say they would do the vaccine. And it really splits in this case by political party. So 70% of Democrats say the reason they would take the vaccine is to help others. 71% of Republicans say I would take the vaccine because it's a personal choice. So there are several groups for which we think the protector story is more important. Those are people who are on the personal choice end of the spectrum, the people who feel the current restrictions are oppressive, they're threatening their freedoms, and the protector motivation gives them that off-ramp to save face, still be invulnerable, still be correct technically, still stick it to the worry warts, but gives them an out, gives them a reason to still take the vaccine. So we don't have a direct sort of controlled study, although we're writing a grant right now to try and test matching and mismatching the message. But in general, my hypothesis, and I think others have said the same thing, that the protector approach should be particularly powerful for people who are in that anti-vax hard no category, who feel the entire movement is a threat to their personal freedoms. And this motivation is a way to diplomatically still allow them to be vaccinated.
And then I guess the only thing I'd add to that, but that might, what I say might cause Ken to come in with an additional comment, is that there's an underlying psychological trait, something called reactance, which is the people's a tendency to push back against orders and authority. And that's a fairly common trait. About 30 to 40% of the US population exhibits fairly good agreement. They tend to agree with statements like when they're told what to do, that make them want to do the opposite, or they become angry when their freedoms are being restricted. So there's a basic psychological trait of reactance, and we think this protector message can be a way to reach those people who are hard to reach using other strategies. Ken has actually done more work on the reactance than I. So Ken, do you want to say more about the reactance issue at all or no?
You did it wonderful. I just added folks who have strong conspiracy beliefs, people who believe in the apocalypse, people believe this is a biologic weapon. We think the protector approach could work with them. because we don't have to necessarily refute those beliefs, which is very difficult to do, particularly if it's actually linked to personality traits like paranoia and other things, which are very difficult to message away.
The other thing I could share, and this is not our survey data, but this is from our focus group data and my conversations with Adam, is that as Ken has said and Sten has said, there are, I mean, these vaccines were developed in record time. There are, and some of your audience are asking about this, but there's legitimate questions and concerns about the speed at which these vaccines were developed. And you know, the one thing that science can't do is science can't tell you about effects 2 or 3 or 5 years from now until 2 or 3 or 5 years from now. There's no way to sort of speed up the clock to have those things happen. I had a conversation with Adam about this, and we talked about his beliefs and attitudes about that vaccine, and he recognized all of these uncertainties, and he expressed all of these same feelings that, yeah, they developed it really fast. I'm not sure I'm so comfortable with that. But the overriding concern to be a protector is getting him in line for the vaccine, right?
That took precedence in his life. So
yes.
In the story. And Linda, you wanted to add something?
Yes, thank you, Neil, and thanks, Larry and Ken. I just specifically back to the question of what kinds of groups does this appeal most to? From our cultural research, we know that faith-based groups believe very strongly in the idea of a protector in their communities. It's in the Bible, and we have actually are speaking with the interfaith nonprofit about bringing in people from all different faiths to talk about this, because it is very revered, the role of protector in families for these, especially for Christian groups. And that also extends to the Latinx community and the Black community, who are very centralized around their houses of worship. So I think that's a really great opportunity to speak to more conservative, traditional audiences who may be not, as keen on more progressive or left-leaning outlets.
Great. So this is my last question to all of you, and thank you all. Then I'll turn it over to Kate, which is, Kate brought up yesterday, I think there was a piece in the New York Times about this Swiss cheese model of protection, which is really clear. And if some members of our audience haven't seen it, can Sten or any of the others just kind of basically tell the audience it's a great metaphor and a great way to kind of visualize protection and being a protector and all of the elements. So Sten.
So let's take driving as a quick example. So I get into the car. Ideally, my eyeglasses are clear and my windshield is clear. I put on my seatbelt. I have a new enough car that I have optimized airbags. And I look both ways as I drive out into the street. I drive the speed limit. I have not had anything to drink. So think about a Swiss cheese model. Each and every one of those elements is a little bit of protection for me in my vehicle. So the same with coronavirus. And this is very much how public health people think. We think about risk reduction. We think about different layers of how to reduce risk. And preventive cardiologists think the same way too. They want to reduce your lipids. They want to reduce your weight. They want to reduce your blood pressure. They want to increase your exercise. They want to check out your genetics. I mean, who knows? I'm a pediatrician. I should have picked a child example. But the point is that we're looking at many different levels of reducing risk. And here we have our classic measures. Masks, excellent but not perfect. Physical distancing, that helps a lot. Hand, face, and surface hygiene, good idea. Small group gatherings, excellent idea. Outdoor activities in preference to indoor. Hey, clever. You got to be indoors. How about optimizing your indoor air quality with MERV 13 filters, 6 air exchanges per hour in your ventilation system, or if you can't manage that, a really good air purifier. And then finally, testing before you go to see a loved one, testing before you go on a trip, testing when you get back, testing when you're symptomatic, and contact tracing for all the people we find who are positive. These are classic public health measures. We've had some of them not so long, like testing for coronavirus. But besides that, they've been around for decades, and some of them have been around for centuries. How do you think we've handled tuberculosis having to do with not crowding people and clean air? And, you know, how do you think we've handled many of these, you know, the plague, bubonic and pneumonic plague? You had mask use and on and on. So the reality is none of that's new. It's classic public health measures. We know it works because it's worked in China, it's worked in South Korea, it's worked in New Zealand, it's worked in Denmark and Norway. And we know when people ignore it, it doesn't work well. Right. As is true in the UK, the US, Spain, Italy, Sweden. So the reality is Brazil. So we know that this can work. So the Swiss cheese model is you put this Swiss cheese with a hole here, put another one, the hole is a little different place, another one, you put all them together, eventually you've got Swiss cheese, but you've got a mat of them and there's no holes in it. That's the basic idea.
Right. So it can get in through the first piece, but maybe by the fourth, it's jammed.
You got it. And
so
guess what? Vaccines are another layer of the Swiss cheese.
Of course.
And it's probably the best layer.
So let me ask one very quick last question of you, Sten, because you brought this up. Should you be wearing your masks after you're vaccinated?
I am going to be wearing my mask after I'm vaccinated. And the reason I'm going to do that is that nobody else knows that I'm vaccinated. And I'm a dean of a school of public health. I'm going to set an example.
You're being a protector.
I'm being a protector. I mean, I came onto, I was going to vote for Donald Trump until I met Larry and Ken, and they turned me and Linda. Now I'm just, maybe that's a joke. But the point is, it is important for us to model. It's important for us to be examples. And until we start seeing really impressive coverage rates, and I also want to see those papers saying that the vaccinated person is considerably less infectious to others.
Right.
So for that reason alone, I'm going to wear a mask. But even after I see those papers, people aren't going to know that I'm vaccinated. I'm going to be wearing a mask for many months to come.
Right. Well, thank you. Thank you all. It's really, the point you're all making is science is not definitive. It is ongoing. It accretes and builds on the knowledge. And so a lot of things we know now and things we still have to learn, which were incorporated in your comments and in the questions. So I want to thank Linda for helping to really spearhead this and organize it, to Larry, to Ken, to Sten, for all of your insights, your examples, and now to Kate to finish up. And thanks to Kate for also making this happen. It was a real pleasure to talk to the four of you, and thank you for all you're doing to protect us.
Yes, thank you. Thank you, everybody. This was fantastic discussion, really, really interesting. And I'm just going to do a quick commercial for all of you writers out there who are interested in either learning more about what you heard today and or integrating it into your scripts and storylines. We are here to help, as always. Just reach out to us at our website or to hhs@usc.edu, and you'll see the email address shortly. Please contact us. We can put you in touch with these guys or other experts to help your storylines. And again, it doesn't have to be a storyline. It can just be a quick scene. You know, we just want to get this modeling out there. Couple other things. On our website, there is a special page where this recording will live, so you can go back and watch it or share it with your friends. And it's a whole page of COVID related webinars that we've been doing since March. So feel free to go there, watch some of the other ones we've done, as well as let people know that it's there who weren't able to make it tonight. We also live streamed on Facebook, so it'll live there on our Facebook page as well. Before you leave, there will be a survey that pops up. We would love for you to give us your opinions on what you learned and what your intentions are and so forth. So please fill out the survey if you can. And then lastly, today, some of you may know, the Supreme Court ruled to, or yesterday, I guess, the Supreme Court ruled to reinstate the FDA policy, which had been suspended during the pandemic, requiring people to go in person to a clinic to obtain a medication abortion, the pills. They did away with that. So now people have to go back in person to access medication abortion. We're going to be talking about that and depictions of abortion on TV on January 28th. So mark your calendars, same time, same station. We've got a great panel set up for that, and we're going to talk about everything that's been going on with the Supreme Court, with these rulings, and how abortion is still really hard to get on TV. And why is that? So please join us again on the 28th. In the meantime, thank you all for coming. Stay safe, stay healthy, wear a mask, wash your hands. Thank you to Neil, to Linda, to Ken, to Sten, and to Larry, and to Marty, and have a good evening.